critically ill patients. Actually, in the next class, the class will be on coagulopathy and bleeding diathesis in ICU. So in this class, actually, I will broadly highlight what are the components and what are the things we use in our ICU. Now, to introduce, transfusion of red blood cells and another blood product is common in intensive care unit. It has been estimated that greater than 40% of patients received one or more red blood cells transfusion while in the ICU, and of which approximately 90% are provided in the context of stable angina. And the appropriate use of blood products require that the potential benefits and risk be carefully weighted for each patient. And indications of blood products transfusion in the ICU are reviewed here, as well as various types of blood products. Now, regarding red blood cells, so what are the indications? Actually, indications for transfusion of PRBC in critically ill patients are the following. Those are acute hemorrhage with hemodynamic instability like hemorrhagic shock, acute anemia with inadequate oxygen delivery like cool vasoconstricted skin, obturations or restlessness, oliguria, anuria, lactic acidosis, an oxygen extraction ratio of greater than 0.3 and or an oxygen delivery of less than 10 to 12 ml per kg per minute, and hemoglobin concentrations of less than 7 to 8 gram per dl depending on the patient characteristics. Now, one thing we need to learn whether we should follow the liberal or restrictive strategy. Initially, the red blood cell transfusions were routinely or whenever the hemoglobin was less than 10 gram per dl. And this practice was based upon unproven physiological and clinical assumptions. However, a hemoglobin concentration less than 7 gram per dl became the accepted thresholds after the multi-center TRIC trial, that is transfusion requirement in critical care. Now, to elaborate the TRIC trial, this trial actually randomly assigned a broad populations of 838 critically ill adult patients to either a restrictive transfusion strategy, that is transfusion threshold less than 7 gram per dl, or a liberal transfusion strategy threshold of less than 10 gram per dl, and found that the restrictive strategy decreased hospital mortality. And among patients who were less than 5 years old or less acutely ill, Apache 2 score less than 20, a restrictive strategy also reduced 30-day mortality. So, these findings have been confirmed in subsequent meta-analysis of trial examining transfusion trigger. Now, the another trial, that is TRIS trial, the transfusion requirement in septic shock trial, that aimed to address divergent views on transfusion in septic shock by determining the impact on mortality of a low versus high transfusion threshold during septic shock treatment. Investigators randomized 998 patients with a septic shock to a low transfusion threshold, that is less than 7 versus a high transfusion threshold, and identified no significant differences in 90-day mortality, that was 43% versus 45%. Despite patients in the low transfusion threshold groups reviewed 50% less red blood transfusions, though they required less amount of blood, and it was less from the high liberal transfusion group, but it was not statistically significant. Now, regarding GI bleed, what we follow in patients with acute severe upper GI bleeding, a lower transfusion threshold is also supported by the evidence. In one trial, 921 patients with acute upper GI bleeding were randomly assigned to receive transfusions when hemoglobin fell below 7 gram per dl versus 9 gram per dl. Patients in lower trigger group had a higher probability of survival at 6 weeks, less ongoing bleeding, fewer complications relative to liberal transfusion group. Importantly, patients with massive exsanguinating bleeding were excluded from the trial. Now, use of a lower hemoglobin concentrations as a threshold for transfusion is also supported by several observational studies that found that red blood cells transfusion were associated with adverse outcome like increased risk of infection, acute respiratory distress syndrome, multiple organ dysfunction and death. A pooled analysis of randomized control trials comparing higher versus lower red blood cell transfusion threshold found decreased hospital mortality in lower transfusion threshold group. However, 60-day all-cause mortality and intensive care unit mortality were not different between the two groups. Now, few exceptions and important exceptions to the transfusion thresholds less than 7 gram per dl is a patient who is having acute myocardial ischemia like acute myocardial infarctions, unstable angina. The optimal transfusion thresholds for such patient is unknown because most clinical trials excluded such patients. However, in TRIC trial, patients with acute ischemic cardiovascular disease had a trend towards improved clinical outcomes when a hemoglobin level of less than 10 gram per dl was used as a threshold for transfusion. Although the improvements were not statistically significant, the effect would be clinically important if real, indicating that larger trials are needed to definitely confirm or exclude such an effect. In a secondary data analysis of Veteran Affairs Intensive Care Unit episodes over a 5-year period, improved outcome was associated with the transfusion thresholds below 8.7 gram per dl in patients with comorbid heart disease and near 10 gram per dl in patients with acute myocardial infarction. To resolve existing controversies, there is a need of definitive trial. Overall, there is an accepted practice to follow restrictive transfusion strategy in most patients, including patients with pre-existing cardiovascular disease. That is, even in patients with pre-existing cardiovascular disease, and there is no additional benefit with excessive transfusion to achieve a fixed higher hemoglobin value of more than 10 gram per dl. Though controversy still exists, it is recommended to use less than 8 to 9 gram per dl as a threshold for transfusion in patients suffering from acute coronary syndrome, and to use less than 7 gram per dl as threshold in patients with pre-existing cardiac disease but stable angina. Now, transfusion thresholds in perioperative patients. So, various studies like FOCUS study, TRACK study and TITRE 2 trial were bound, but all were inconclusive. And American Associations of Blood Banks recommends thresholds of 8 gram per dl for patients undergoing orthopedic and cardiac surgery, including patients with pre-existing heart disease. Thresholds of 7 gram per dl may be comparable to 8 gram per dl, but there is no evidence still. Now, transfusion thresholds in neurocritically ill patients. So, in traumatic brain injury, the hemoglobin target is 7 to 9 gram per dl, means the thresholds to transfuse. In traumatic brain injury with cerebral ischemia, the target is hemoglobin more than 9 gram per dl. The subarachnoid hemorrhage, the target is 8 to 10 gram per dl, and in stroke, it is more than 9 gram per dl. Now, transfusion thresholds in trauma patients. So, hemorrhage in trauma patients follow restrictive strategy of hemoglobin 7 gram per dl. Other factors to reduce blood transfusion in ICU can be implemented, like measures to stop ongoing bleeding, correct the lethal triad of coagulopathy, acidosis and hypothermia, stop unnecessary anticoagulant and antiplatelet agents, use of antifibrinolytic agents like tranexamic acid, epsilon aminocaproic acid, especially in early trauma, supported by CRASH 2 trial, techniques of self-salvage during surgery, use of blood conservation devices while sampling. Now, weaning from mechanical ventilation. So, clinical guidelines recommend hemoglobin of 7 gram per dl and suggest not to use blood transfusion to facilitate weaning from ventilator. Now, RBC preparations. So, RBC red blood cells transfusion may be performed using packed red blood cells, whole blood or salvaged autologous blood. So, PRBC packed red cells are the preparation used in most clinical situations. Each unit of packed red blood cells has a total volume of approximately 300 ml, of which approximately 200 ml are red blood cells. Whole blood is rarely indicated and seldom is available nowadays. Its use should be considered only in the context of massive blood transfusion. The rationale is that massive transfusions of only one blood component, that is red blood cells, will lead to dilutional deficiencies of other components, that is platelet coagulation factors. This can be avoided by transfusing whole blood. Now, leukodepleted blood, it filters donor leukocyte from PRBC, packed red blood cells, thereby aiming and attenuating transfusion associated reactions. The advantages are effective for the preventions of HLA and HPA immunization and platelet refractoriness, especially in high risk patient, decreases the trend of alloimmunizations and graft rejections in the cases of multiple surgeries related to solid organ transplant, prevent the risk of infection of CMV, Epstein-Barr virus, HTLV transmission, and prevents the risk of febrile non-hemolytic transfusion reactions. Now, the disadvantages are 10% of RBCs are inadvertently removed during filtration. RBCs are even hemolyzed during processing when decreases oxygen carrying capacity. Now, artificial bloods. So, there are two types of artificial blood, that is perfluorocarbons and hemoglobin based oxygen carriers, that is HbOC, and the risk of spreading infections of disease is eliminated by use of them. Limitations includes they have short half-life, like 20 to 30 hours in the body, and they do not perform other functions of blood such as coagulation. Autotransfusion. So, autotransfusion refers to collection of patient's blood during acute blood loss followed by transfusions of the blood back into the patient. It is preferred techniques whenever the collection device is rapidly available or a large volume of blood loss can be anticipated, like in certain surgeries. Autotransfusion facilitates rapid transfusions of immense quantities of blood, which is generally collected from chest tubes or aspirated from the pleural or peritoneal cavities. It may be particularly valuable for patients who have multiple alloantibodies that precludes the transfusions of donor blood, and autotransfusions are acceptable to some Jehovah's Witnesses as long as the blood does not leave the bedside for processing. Autotransfusion system damage the red blood cells to some degree. Therefore, it is recommended that the volume of an autotransfusions be limited to less than 10 to 15 liter if possible. A systematic review of evidence confirms that autotransfusion reduces the need for donor blood transfusions. Now, RBC alternatives. So, erythropoietin is an endogenously produced hormone that stimulates erythropoiesis provided that stores of vitamin B12, folates and irons are adequate. Endogenous productions of erythropoietin normally increases with anemia and hypoxia, but this response is blunted during critical illness. So, the use of recombinant erythropoietins in critically ill patients has been studied in 3 randomized trials with conflicting results. Interpretations of these studies is confounded by variable dosing regimens and variable thresholds for red cell transfusion. However, the preponderance of the evidence does not support the routine use of erythropoietin in critically ill patients. 2 trials have demonstrated a survival advantage with the trauma subgroup of critically ill patients despite no significant decrease in red cell transfusions. The explanations for this finding has not been established. And the RBC responses after transfusions, like the transfusions of 1 unit of PRBC can be expected to raise the hematocrit by roughly 3% and the hemoglobin by approximately 1 gram per dl, assuming that there is no ongoing bleeding. And regarding RBC age, so similar to that observed in other populations in critically ill patients, the age of transfused red blood cell does not appear to affect outcome, including the mortality, and that was supported by ABEL trial, INFORM trial, TRANSFUSE trial and RECESS trial. So, next the plasma products. So, plasma is the portions of whole blood that remains after the cellular elements, that is red and white blood cells and platelets have been removed by centrifugation. And the indications of plasma transfusion, the indications for transfusions of plasma in critically ill patients are less well established than the indications of red blood cells. Generally speaking, transfusions of plasma is indicated whenever hemostasis is inadequate and the benefit of correcting the insufficient hemostasis, like reduced bleeding, is believed to outweigh the risk of plasma transfusions. However, the benefits of plasma administration remains controversial. Now, examples of situations in which plasma transfusions are often administered include the following, like active bleeding in the setting of known or strongly suspected coagulations abnormalities, massive transfusions of packed red blood cells. The rationale is the massive transfusions of red blood cells alone will lead to dilutional deficiencies of coagulations factor, which can be corrected via the transfusions of plasma. The practice is supported by several studies of massively transfused trauma patients, in which the protocols with the predefined ratios of plasma to red cells transfusion reduce the total blood product use, reduced organ dysfunctions, and improved survival. That is supported by prompt and proper study. And prior to invasive and surgical procedures for which there is a high risk of bleeding complications like thoracic, abdominal, spinal, intracranial, and some urologic surgeries, if the patient has any potentially significant abnormality of their coagulation test, that is PT, INR or APTT. And when deciding whenever the abnormality is potentially significant, the relationships between the severity of an abnormal coagulation test and the response to plasma should be considered. Prior to invasive procedures for which there is a low risk of bleeding complications like endoscopy, cardiac catheterization, central venous catheterizations, if the patient has a severe abnormality of their coagulation test like PT more than 2 times of normal, INR more than 2, and APTT more than 2 times of control, plasma transfusions may be required, and transfusions of plasma is not indicated prior to such procedures if the coagulation tests are only mildly abnormal. Now, plasma preparation. So, there are several different plasma preparations available, including fresh frozen plasma, thawed plasma, liquid plasma, cryoprecipitate, and factor concentrates. So, in this chart, we can see the preparation process. Like this is whole blood. We separate the platelet rich plasma and packed red cells by centrifugations, and if we this pathway, then we again centrifuge it at 20 degrees centigrades. We get platelet pore plasma, and platelets get separated here, and if the platelet pore plasma is freezed at minus 20 degrees centigrade, we get fresh frozen plasma, and if it is freezed in minus 70 degrees centigrade, we can separate the factor 8 pore plasma, and if we thaw it at 4 degrees centigrade, we can get the cryoprecipitate. And fresh frozen plasma, the fresh frozen plasma is separated, that I have said, from freshly drawn blood by removing the red blood cells, white blood cells, and platelets. It is then frozen and stored and thawed when needed for transfusion. Once it has thawed, the plasma must be transfused within 24 hours of concentrations of within 24 hours, or the concentrations of factor 5 and factor 8 begins to decline. FFP is the most commonly used plasma product, in part because it can ameliorate deficiencies of any circulating coagulation factors. FFP need to be ABO compatible but doesn't require cross matchings or RH typing. And thawed plasma, FFP become thawed plasma if it is not transfused within 24 hours of being thawed, and thawed plasma can be transfused up to 5 days after being thawed if stored at refrigerator temperature like is 1 to 6 degrees centigrade. Cryoprecipitate is collected by thawing FFP at 4 degrees centigrade and collecting the white precipitate. It is rich in von Willebrand factor, factor 8, factor 13 and fibrinogens. The chief advantage to cryoprecipitate is that it allows VWF factor 8, 13 and fibrinogens to be replaced using a much smaller volume than if those factors were replaced by transfusing FFP. Now, factor concentrates. A factor concentrates contains a large amount of specific clotting factor that has been produced with recombinant technology or collected from thousands of donors and pooled into a high concentrated product. And PCC, it comprises a group of products containing vitamin K dependent factors, and in the past the major indications for these products is to replace the specific factor deficiencies like in hemophilia A and B with minimal volume and without supplying extraneous proteins. And recombinant proteins also have the advantage of being free from viral contaminations. However, there has since been a paradigm shift in the administrations of 4-FPCC that has been applied for warfarin reversal by US FDA. and there are two types of PCC, like 4-factor PCC and 3-factor PCC. And liquid plasma is prepared by removing the red blood cells, white blood cells and platelets from previously stored whole blood. Its use is extremely rare because it has low level of factor 5. However, in some situations FFP is unavailable and the coagulopathy is likely due to deficiency of factor other than factor 5, then it is required. Now, intravenous immunoglobulin. Intravenous immunoglobulin is the purified immunoglobulin fractions of plasma pulled from several thousands donors. It is useful in the treatment of some autoimmune and immunodeficiency status. Now, regarding desmopressin may also be useful in achieving hemostasis during the short-term management of patients with certain type of von Willebrand disease, mild hemophilia A or uremic platelet dysfunction, since desmopressin induces the release of multimer of factor 8 and von Willebrand factor from endothelial cells. Now, regarding platelets, so indications of transfusions are for the transfusions of platelets in critically ill patients may be therapeutic to stop active bleeding or prophylactic to prevent bleeding. Patients with platelet count less than 10,000 per microliter, this is one indication. The purpose is to prevent spontaneous hemorrhage. And patients with platelets less than 50,000 who are actively bleeding are scheduled to undergo an invasive procedures or have a qualitative intrinsic platelet disorders. And patients with platelet count less than 1 lakh per microliter who have a central nervous system injury, have multi-system trauma, are undergoing neurosurgery or require an intrathecal catheter for anesthesia. And patients with normal platelet count who have ongoing active bleeding and a reason for platelet dysfunction such as a congenital platelet disorders, chronic antiplatelet therapy or uremia. Special consideration needs to be given to the indications for platelet transfusion in the following conditions, like heparin induced thrombocytopenia, TTP, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, disseminated intravascular coagulations, thrombocytopenia associated with antiplatelet alloantibodies and immune thrombocytopenia. In these conditions, platelet transfusion is typically reserved for life-threatening bleeding. This is because platelet transfusion in these settings is often less effective due to platelet consumptions like DIC or associated with clinical worsening due to additional thrombosis like in TTP. Now, platelet preparations, platelet may be prepared for transfusion in variety of ways. So, pooled concentrates from whole bloods, sequential steps that involve centrifugations at different speeds. While this technique is less expensive than the alternative, more donors are required because the yield is lower. 6 to 10 donors may be required per platelet transfusion. And for single donor apheresis concentrates, platelets may also be obtained by apheresis, a procedure in which the whole blood from a donor passes through a device that separates and collects the platelets, then returns the remainder of the whole blood to the patients. This technique is more expensive, but the yield is high and fewer donors are necessary. Only one donor is necessary per platelet transfusion. Small amounts of donor erythrocytes, leukocytes and plasma are transfused along with platelets, which may sensitize the recipients and make subsequent red cell transfusions more difficult. ABO matching of platelets and recipients is not essential, but it is preferred because ABO incompatible platelets may have shortened survival and incompatible donor plasma may produce a positive antiglobulin test and a small degree of hemolysis, like acute hemolytic reactions though doesn't occur. And Rh negative women of childbearing age should receive only Rh negative platelets unless none are available. In those situations, they may be given Rh positive platelets along with a dose of Rh immunoglobulin appropriate for the amount of red blood cell contamination. Now, platelet response. Each unit of transfused platelets should increase the platelet by 5 to 10,000 per in an average 70 kg adults per unit. Thus, a transfusions of 6 unit of platelets can be expected to increase the platelet count by 30,000 per microliter, and platelet destructions may decrease the response to a platelet transfusion. When the platelet destruction is due to the presence of alloantibodies, single donor platelets and HLA mass platelets may be more effective. Complications are immunologic reactions. Like immunologic complications of blood product transfusions includes acute hemolytic reactions, delayed hemolytic reactions, febrile reactions, allergic reactions, acute lung injury, post transfusions purpura, and immunodilution. And for acute hemolytic reactions, the managements are the patients may present with fever, tachycardia, dyspnea, back pain, hemodynamic instability, and we should stop the transfusions immediately. The general managements are like same: ABC, cardiac monitoring, oxygen monitoring, and we should recheck the patient's name, recheck typing, send the blood and tubings to the blood bank, and the laboratory test to do the CBC, cum test, urine test, urine free hemoglobins, haptoglobulin, PT, APTT, fibrinogens, bilirubin, LDH, and the IV fluids we can start with D5 with 3 ampoules soda bicarbonate at 250 ml per hour. Keep urine output more than 30 to 50 ml per hour. And the medications we usually use, that is steroid injection, hydrocortisone 100 milligram IV we can give. The antihistaminic diphenhydramine 50 milligram IV we can give, and others are acetaminophen, and in resistant cases or if we feel it is required we can use epinephrine 0.3 ml of 1:1000 subcutaneous, or we can start adrenaline infusion also. IV excess, if a systolic BP is less than 100 mmHg or additional sign of poor perfusion, administered 1 to 200 ml of normal saline if available. If deteriorating despite IM epinephrine, then we consider 1:10 lakh adrenaline infusions, that is 1 milligram or into 1000 ml of normal saline, or 0.5 milligram into 500 ml of, or like in the similar wise 0.25 into 50 ml of normal saline, and the standard rate of administrations 1 to 2 ml per minute titrated to clinical effect. Infusions can be increased up to wide open if it is required. Now the non-immunologic reactions of blood transfusions are volume overload, hypothermia, coagulopathy, citrate toxicity, acute lung injury, and post transfusions. Thank you.
টিম এসে সব রেকর্ডস দেখে, হ্যাঁ, একটু আপলোড যে কত প্লেটলেট কাউন্ট হলো, কত ফ্লুইড দিলে, কি প্লেটলেট দিলে নাকি সব আপলোড করতে হবে। সো সেটাই জিজ্ঞেস করছি। ঠিক আছে, বাট দ্য প্র্যাকটিক্যাল প্রবলেম ইজ যে if you send the blood for platelet today, you will this morning extend করলে তুমি late afternoon এ একটা রিপোর্ট পাবে। machine count of it or a manual count of it, which might all be quite different. And we generally rely on the manual count. Though to me, it is portion of the manual count rely on you, machine count rely on that. Is it correct all the times, or is it in certain specific times you should do that? এবারে তুমি ওই কাউন্টটা দেখে নিলে, এবার তুমি নেক্সট যখন সন্ধ্যাবেলা ব্লাড পাঠালে তার রিপোর্টটা তুমি আবার পরের দিন পাবে। এখন পেশেন্টের যদি 23,000 24,000 আসে, অনেকটা যে 9,000 আসবে না তুমি জানো না, স্পেশালি উইথ দ্যাট ডাউনওয়ার্ড ট্রেন্ড। আর দিস গাইডলাইনস আর অল গুড, বাট দে আর ইন সেটিংস ওয়ে তুমি বললেই প্লেটলেট পেয়ে যাবে আর কি, রিপোর্টসগুলো চট করে চলে আসবে। সো মানে এভরিবডি হ্যাজ অ্যাডপ্টেড sort of a threshold, but certainly not 10,000.
We can do it 20.
Yeah, I'm actually ওটাই reason যে আমরা if you had a monitor with continuous platelet monitoring দেখাতো, then and you had good supply of platelets. Our platelet তুই জানো ওটা বেশি রাখা যায় না। সো সেদিনকার ডোনেশনের ওরা প্লেটলেট তুমি সকালে পাঠালে রাত 12টা 1টায় ব্লাড আসে। unless there is a apheresis machine or site and there is a donor, now it takes time. That is an issue. Our use of platelet, thrombopath, etc. in আমরা প্যানসাইটোপেনিয়া পেশেন্টের তো চিকিৎসা দিই, তাই না, ফিগাস্টিন এটসেট্রা। তাতে we generally are doing it for the white cell count, but these agents are now available. I came across only a very small study, not from a very reputable journal, like I wrote it on bar. এখানে সার্জারি করা এত ঝামেলা ঝঞ্ঝাট, জানো যারা সব থিসিসের ethics committee দিয়েছে, তাই না? Otherwise, you would so many derivation, you could easily give and see কি হয়। পেঁপে রস খাওয়ানো is you could get these capsules for carry papa,
yeah.
Platelet is a problem. The guidelines apply in a certain setting. Our setting may not necessarily, so we'll have to be a little bit more cautious. I can say the P-time and procedure. এখানে সিটি গাইডেড ড্রেনেজ, এফএনএম, অ্যাসপিরেশন এগুলো করতে পাঠালে ওরা 1.5 দেখলে ওরা করে, তাই তো? এটা নিয়ে we had a big in that hospital and I remember actually presenting data. It's a ascitic tab. মানে patient is already behind this does not matter, and you don't even need to give use of FFP আমার মনে হয় somehow certainly in this hospital I see excessive use of FFP. I've seen it in CCU patients, I've seen in renal patients. I see there which probably does not match what you say, because FFP is not harmless. Of the blood product, it is probably one of the most liable to give ALI, etc. FFP to in liver disease scenario, liver coagulopathy scenario, you lose the value of measuring the P-time. Therefore, you are making a lot of points, so you don't know which way things are going. Our number correct করে দিলে, মানে কারো P-time ধরো INR3 আছে, তুমি তাকে দিয়ে দিলে তারা INR normal হয়ে গেল,
it doesn't eliminate the risk of bleeding.
So unless
this is transient, depends on the half-life of the factors.
Oh, it doesn't increase the outcomes then. Unless, somebody's being on warfarin, somebody's on gross coagulopathy and they're actively bleeding. Because routinely chronic liver disease patient is not, the other blood product we have not talked about is albumin, which is also a blood product, does not come in this category, but Otaro used is perhaps
massive gas function,
overused, not rational. Actually, I could খুব use হতো resuscitation and that সবই use হতো, কিন্তু আস্তে আস্তে সব পড়ে যাচ্ছে। And it would be useful the ব্যাংকে গিয়ে একটা দিন কাটানো, ব্যাগ কি একটা প্যাক্সেলে আমাদের এখানে কত আরবিসি থাকে,
350 মনে হয়, 350
কোয়াগুলেশন থাকে, আর কি থাকে, লেখাও থাকে উপরে জানা ইউজফুল। যদি কোয়াগুলোপ্যাথি হয় from massive transfusion দেওয়া, so they are either bleeding or something, so that they are losing. Be what you are giving, if you are not replacing protocol করে করে আমরা 5-6 ইউনিট ব্লাড দিলে 4 ইউনিট FFP দিয়ে থাকি ওরা পয়েন্ট, তো rule of thumb. আর this contains anticoagulant, এটাও যা ক্যালসিয়াম গুলো দিতে হয় যদি ম্যাসিভ ট্রান্সফিউশন।
ERBC ট্রান্সফিউশন ট্রিগার যেটা 7 or 8, আমি সবাই কাজ ইচ্ছে করেই বলি, 7টা ইস্যু একটু উইলফুলি ইগনোর করি। এবার প্রশ্ন হলো একটা রিসেন্ট ধরো একজন 12 হিমোগ্লোবিন ছিল, তার ওভার এ পিরিয়ড অফ 3 মান্থস 12 থেকে 7 হলো। আর আমরা ওটিতে একটা অপারেশন শুরু করলাম 12 দিনে, হ্যাঁ, এমন বিল্ডিং হলো ইন 3 আওয়ার্স টাইম ইট বিকেম 7 আর দ্য সেম
না আচ্ছা দ্যাটস ওয়াই
ট্রিগার টাইপের একটা আমাদের টেকনিক্যাল অ্যাকুইপমেন্ট কাজে লাগে, ইট ইজ নট দ্য সেম
compensation.
সুযোগ আছে না।
আরে ওটাই যে
হ্যাঁ, মানে অপরদিকে
একই ধরনের যে দেওয়া কষ্ট যায়
ওয়েট করবেন টিভি স্যার ধরো আমাদের অপারেশনগুলোতে যেগুলো হয় কন্ট্রোল ডেমারেজ হয়তো হচ্ছে ধরে নিচ্ছে, আমি 12তে শুরু করলাম, আমি হয়তো 8-এ গিয়ে পৌঁছলাম, আমি কি 7 দিয়ে ওয়েট করবো না 8-এ দিয়ে দেবো নাকি 9 দিয়ে কিন্তু ইন্ডিকেশন তো রয়েছে দেখো
Acutely hemorrhagic, we should give transfusion.
With hemodynamic instability, so the moment you start developing hypotension, this is
আমার এখানে হেমোগ্লোবিনের কোনো রোল নেই।
যে সাহারি অ্যাকিউট আইসিইউতে রয়েছে, সেপসিস রয়েছে, 70 বছর বা সিওপিডি রয়েছে, সিআরসি রয়েছে, সে বাড়ি থেকে আসা পর্যন্ত অ্যাম্বুলেন্সে পেয়ে গেছে, তার একটা মিনাস টুল হয়েছে। এবং that is that sort of a scenario. You could use judgment, but basically এটা কেন এসেছে যে ব্লাড তো এটা availability, ব্লাডের ঘাটতি হয় এটসেট্রা, and blood itself causes primary trauma, the systemic inflammatory response of ALI, etc. And reverse study আছে যেখানে early goal directed therapy, etc. ওখানে কিন্তু 10 ছিল, ওখানে অব্দি 10 ছিল, and that was in the early 2000 study. তার আগে যদি তুমি দেখো 90s এর ইস্যু ম্যাটার এটসেট্রা, যে অক্সিজেন ডেলিভারি আর অক্সিজেন ওইগুলো নিয়ে ওখানে হিমোগ্লোবিনের রোল হচ্ছে না 10 মানে তুমি ডেলিভারিটাকে অপটিমাইজ করতে চাইছো। 10-এর বেশি কেন বলতো না why not 12? তখন যেটা বললে যে আনসাবস্ট্যান্সিয়েটেড অ্যাজাম্পশনস ছিল ফিজিওলজিক্যাল, যে ওই যে হিমোরিওলজ ব্লাড ফ্লো, ব্লাড ভিসকসিটি, ওগুলো বিকাম অ্যাডভার্স। কিন্তু আজকালকার দিনে পিপল ডু আউটকাম স্টাডিজ, হচ্ছে যে ওটা ভিসকসিটি বাড়ে, ওটা অক্সিজেন 10 ভালো, কিন্তু 10 আর 7 তো দেখাচ্ছে যে মোস্ট সিচুয়েশন you are able to get away with lower. That is the whole and you always have to keep the context. You are the best person to judge in that situation. এরকম প্লেটলেটের আমরা বলবো আমাদের এখানে তুমি 22-23 হলে you will worry, কারণ next you will hear the patient has had an ICH or an intraocular bleed or something like that. And then মানে ইসকেমিক হার্ট, এটা ওই দুটোই আছে, তুমি স্ট্রোক আর এটাও বললে সেরেব্রাল ইসকেমিয়া আর এদিকে মাথালের মাঝে, those sort of situations are the only one where you have to keep it slightly higher.
যেমন 9+ এর উল্লেখ করেছো মোরল, সেরিব্রোভাস্কুলার কার্ডিওভাস্কুলার ডিজিজ।
আরেকটা পয়েন্ট যেটা ডেঙ্গু রিলেটেড, বিকজ ওখানেই আমরা সবচেয়ে বেশি প্লেটলেট আমাদের সিচুয়েশন রাখি, যে most patients who die, they die of sort of shock and capillary leak and multi-organ failure rather than just thrombocytopenia or thrombocytopenia related bleeding. এটা একটা ওখানে ওই একই যখন পিক অফ ডেঙ্গু সিজন তখন প্লেটলেট পাওয়া ঝামেলা হবে।
একটা থেকে মানে স্টাডি আছে অ্যাকিউট হেমারাইটিসের ক্ষেত্রে হোল ব্লাড ট্রান্সফিউশন, মানে নট পুরনো নয়, নতুন 15 days 20 days ওল্ড অ্যালাউ করতে, তাহলে হোল ব্লাড
মানে দেখো তোমাকে বুঝতে হবে যে ব্লাড ইজ আ প্রেশাস রিসোর্স, আর you can get a lot of component therapy of chemical blood. So in modern day medicine there is almost মানে আমরা যখন স্টুডেন্ট ছিলাম তখন স্পেশালি গাইনিতে দেখতে পেতাম তারা ফ্রেশ হোল ব্লাড চাই, ওখানে ফ্রেশ হোল ব্লাড তুমি পাবে আজকাল, unless আপনি immediately donates and etc. আর তার আইডিয়াটা ছিল যে you get your coagulation, so only trauma patients যেখানে ব্লাড ক্লট নেই, কেন কি ব্লাড আছে কার্বনের আছে কিনা immediately donate করলো দিয়ে দিলে you can give it, otherwise there is no, you replace what is required. বড় ব্লাড মানে আমরা আসলে ডাক্তার তো বলছি যে না ইমিউনিটি কম আছে একটা মিনিট দিয়ে দাও হাত দিলে চাঙ্গা হয়ে যায় সো ওই কতগুলো বেরোলো না অ্যাফোরিজম there is no indication for 1 unit of blood there is no indication of whole blood there is no indication of fresh whole blood except in traumatic একটা পয়েন্ট আমি বলেছো বাট ওটা not related to blood transfusions related to the blood pressure see this was they found it in the Iraq war but a lot of this blood research happens in war times না অটো ট্রান্সফিউশন না যেটা হচ্ছে যে বেশি ট্রান্সফিউজ করলে আউটকাম খারাপ হয় এটা হচ্ছে যে in trauma patient they were previously resuscitating to a higher blood pressure 110 and ওরা হচ্ছে যে ক্লটস গুলো ফর্ম হয় in various trauma areas etc blood pressure তুললে ওই ক্লট গুলোকে dislodge করে দিচ্ছে so you should aim for just about microsystolic just একটা several function confusion ওইগুলো একটু that's about it so কি বলবো যে সব কিছুরই থ্রেশহোল্ড কমে যাচ্ছে অটো ট্রান্সফিউশন তো ওই ওটাও যে Jehovah's Iron Doctor is not here but there was a patient who had a hemoglobin of 2-3 he was going to need a liver transplant so ওরা Jehovah's Witness ওরা ট্রান্সফিউশন নেবে এদিকে ট্রান্সপ্লান্ট করতে হবে তখন সবাই বসলো কি করবে না তখন সেল সেভার বলে পাওয়া যায় ওই জিনিসটা তখন the Jehovah's Witness ওরা ওই whatever their organization they donated at that time I'm talking 25-30 years ago 25 years ago at least cost 20,000 pounds so the patient had a liver transplant মানে করা যায় এখন হাসপাতালের কাছে থেকে গেল ওই সেল সেভারটা then they were using it for other আর এখানে তো কার্ডিয়াক সার্জনরা তো রেগুলারলি আগে থেকে ব্লাড পেশেন্টের ব্লাড আগে থেকে যদি ইলেকট্রিক নিয়ে রেখে যায় that is also auto transfusion but that is not acute but এই অপারেশন করার সময় ওই সাকশন করছে আর যাচ্ছে এটা whatever happens and they are putting it in extra corporeal therapy interesting
এখানে আমাদের যদি করা হয়েছে বিয়োগগুলো তেরো চোদ্দ তাকে বলা হলো ব্লাড মনে পড়ে যেতে সেই বিয়োগটা আবার ঠিক প্রয়োজন হবে বাট যদি সেন্সিবল টেকনোলজি আমাদের নেই বলে সাকশনের ব্লাডটাকে আবার ডিরেক্টলি পাওয়া যায় না এটা আসলে বলতে হবে সেটা হয়ে ওঠেনি বিকজ দ্যাট is not there.
So we need some Jehovah's people to donate it here. মানে তোমাকে যারা সার্কুলেট সার্জন আপনি যদি এসে বলে যে এই করতে হবে কিন্তু ব্লাড দিতে হবে না অ্যাড্রেস বলবে যে বাবা চলে যাবে রেফার করবে স্পেসিসকে ফায়ার সেন্টার
ম্যাসিভ ব্লাড ট্রান্সফিউশনে একটা স্পেসিফিক কোড আছে কোড মানে তো আসলে চালু হচ্ছে কিন্তু তাদের পরে কোড ওমেগা এটা চালু হচ্ছে আমাদের হাসপাতালে
কি what is that
মানে কোন জায়গায় যদি ম্যাসিভ ব্লাড ট্রান্সফিউশনের কোনো খবর হয় ইন্টেনসিভ কেয়ার বা ওটি থেকে সিস্টেম চালু হচ্ছে এখানে ডেডিকেটেড নাম্বার থাকবে এটা দিয়ে
খবরটা কার কাছে যাবে
সবাই পেয়ে ব্লাড ব্যাংকে ডেডিকেটেড লোক থাকবে
যদি ম্যাসিভ ট্রান্সফিউশন থাকে তো ব্লাড ব্যাংক অলরেডি
ব্লাড ব্যাংকে যে নিয়ম হচ্ছে কিছু ও নেগেটিভ ব্লাড ওদেরকে রেখে দিতে হবে এবং যখনই ওই কলটা হবে তখনই ওই ফরম্যাটে ওরা ওই জিনিসটাকে স্পিড বাড়ানোর জন্য কিছু কিছু প্রোটোকল তৈরি করা হয়েছে যাতে কিনা মিনিমাম রেটে থাকবে আর কি দ্রুত জিনিসটাকে
green corridor I mean the largest volume of blood I have ever sort of transfused is about 21 units overnight. Oh, good. The patient I was on call and the patient came in with a jet, massive jet. So when I দুটো নার্স তো খালি ওই শিফট চেঞ্জ করছে because the guy is pouring আমাদের 4টে লাইন ছিল আর 4টে লাইনে দিয়ে ব্লাড স্কুইজিং ব্যাক করে দেয় বাট এখানে এত গোইং সো ফাস্ট we were actually manually squeezing so the patients were getting যখন 8-10টা ট্রান্সফিউজ হয়ে গেছে by the time the old file arrived and I saw the patient had small cell cancer, lung cancer, respiratory ছিল। আমি বসকে ফোন করলাম যে আমরা চেষ্টা করলাম যথেষ্ট তো small cell lung cancer আছে, do you think it's worth pursuing it any further? Well, she did not know his cancer was responding well to chemotherapy. I think we should give him our best shot at it. আরো 10-11 মিনিট ট্রান্সফিউজ হলো, বিপিটা ওই 90 বাই 4 এর দিকে ওর মেলিনা অ্যাক্টিভলি হওয়াটা বন্ধ হয়ে যায়। অ্যাক্টিভলি হওয়া ইন দ্য সেন্স যে পারফেক্টম কিছু হচ্ছে না। সো দেন উই স্টপড। সকালবেলা গ্যাস্ট্রো ফোন করলাম, এন্ডোস্কোপি হলো, একটা ব্লিডিং আলসার ছিল, ওটাকে ওরা বলে করে দিল, পেশেন্ট মারি যায়। So it changes your perception, কিন্তু I can't imagine there's nothing here.
এখানে হয়েছে, এখানে 40 নিউমেট স্টুডেন্ট এখানে হয়েছে। বিকজ আমাদের এই ছিল না, কৌশিক নন্দী ওই বড় পেলভিক সার্জারি করেছে। হ্যাঁ, সিনক্রেট নিউমেট অপারেশন।
হ্যাঁ, those will be
মানে সেটা এখানে
অটোমা একটা অপারেশন করেছিল।
এই ডিউল অফ 16 18 20 মিনিটস হয়েছে।
If you have things like a, like a tubal rupture or something, ওখানে তো ঠিক আছে, তুমি stop দিয়ে দাও, তারপরে তো you take the patient to OT, immediately খুলে whatever they clamp করে দেয়।
এফএপি কি কম্প্যাটিবিলিটি লাগে, মানে এফএপি যদি চাই সেটা এবিও লাগে, আরএইচ লাগে, তাই তো? লাগবে কেন এবিও সুবিধা দিয়েছে?
No, because it is never pure. You always have. So that's why if it is not RH compatible, platelet হবে, এইসব হোক, and if the patient is RH negative, তাহলে কোনো অ্যান্টিডি দেওয়ার ব্যাপার নাই।
মানে সেম ব্লাড গ্রুপ ও আইচ কম্প্যাটিবল হতে হবে।
হলে ভালো হয়, কিন্তু দেওয়া যায়।
অ্যাট লিস্ট এবিও হলো দরকার।
প্লেটলেটের তো দেওয়া যায়, বিকজ তুমি দেখো যেটা খুব সুন্দর স্লাইড দিয়েছে, ব্লাড থেকে রেফারেন্স করে
এর কম্প্যাটিবিলিটি দিয়েছে।
এফএফপিটা আগে আছে।
I think that's it, is very nice.
These should be compatible, doesn't require cross-matching and analysis.
ওকে, আর হচ্ছে এবিপি দিতে তো এবিও কম্প্যাটিবলি হবে। প্লেটলেটস that is required.
প্লেটলেটে you may give without it, কিন্তু যদি ওই RH নেগেটিভ পেশেন্ট থাকে তাহলে তোমার অসুবিধা হবে।
এটা
আরেকটা যেটা অ্যান্টি ডি যেটা আছে আমাদের এখানে, সেটা ইজ নট না অ্যান্টি ডি অলসো puts your platelet count up, মানে IVIG এর মতনই কাজ করে। The preparation available here is not an IV preparation, it's an IM preparation. So একবার হয়েছে যে এরকম ITP যে র্যাশ হচ্ছে, count up, etc. It's time to give an iron injection to come over. That ED preparation, which is recommended for improving platelet count, and when you have an immune thrombocytopenia. So the preparation we have here is only an iron injection.
তো ওটা আপনাকে প্রসিডিউর বলতে সেক্ষেত্রে হোয়াট ইজ দ্য রেকমেন্ডেশন? প্লেটলেট আর আয়রন অ্যাডমিশন লেস দেন 1.5 প্লেটলেট কত অনেকগুলো ভ্যালু দেখলাম, মানে কত 50 কত
Active bleeding less than 50,
আচ্ছা, আচ্ছা।
prevent করার জন্য less than 10.
প্রসিডিউর হচ্ছে
Procedure for the encephalopathic and bleeding from everywhere. ওখানে
then our platelet target is 50,000. We don't follow the IMA.
লেস দেন 1 লাখ না
CNS বা ব্রেনে কিছু করবে।
RES brain. আচ্ছা, এই আজকাল তো you are finding a lot of people on Sikdar who are coming for surgery. কি করো?
40 hours
আর আমাদের পোস্ট অফিস কারোর কোনো এবি পজিটিভ ব্লাড গ্রুপ পাওয়া যাচ্ছে না, আইদার এ পজিটিভ বা পজিটিভ ব্লাড, এটা
হয়েছে আমাদের ও নেগেটিভ তো প্রায় বলতে পারবো কি না হয় না
নেগেটিভ এইগুলোর কোনো প্রবলেম
I think দুটো ইস্যুস আছে, একটা হচ্ছে মেন্টাল প্রবলেম, একটা লিগাল। সো ওনে তুমি দিয়ে দিতে সেটা you will not have easy.
এবি পজিটিভ কি এই পজিটিভ হবে
হ্যাঁ, ওটা হচ্ছে, ওটা it will be hazardous. or unless you have consent and you have another colleague, transfusion specialist or somebody, আসলে তুমি কথাও বলে নিয়ে সেটা বলে হ্যাঁ যদি patient or die without it, then you the major reaction দেখেছো? Blood transfusion major reaction মানে
হ্যাঁ অ্যানাফাইল্যাক্সিস দেখেছি, অ্যানাফাইল্যাক্সিস দেখেছি অ্যাবসেন্স,
very frightening.
মানে হাইপোটেনশন, শর্টনেস অফ ব্রেথ, adrenaline nebulizations, IM adrenaline.
Can I see where in the early days we had a patient and বিদেশে মানে at least UK the rule was if you had something like that you take a fresh sample of the patient's blood and the remnant blood back ওগুলোকে সব ওদের একটা প্যাকেটে করে blood back পাঠিয়ে দিতে হবে and they would recheck, regroup the দুটোই আর কি, back example, director sample, and then sometimes you have these funny antibodies which cause not necessarily
other antibodies.
Bombay we had a patient.
Recently had a patient support.
ওটাই কিন্তু এখানে সমস্যাটা হচ্ছে যে everybody becomes a little bit crazy to do a lot of testing, তাহলে দেখা যায় যে তোমার তখন the blood used to all come from Gouranga. Gouranga আছে না উঠে গেছে এখন নেই, Gouranga blood bank বলে it was one of the most okay they said patient had an acid required intubation ventilation and the adrenaline. Good, thank you. So next week is
Coagulopathy in ICU, coagulopathy and thrombotic disorders in ICU.